Our final speaker in this session is Paul Yu, who's a cardiologist at Brigham and Women's Hospital and whose program is interested in molecular approaches to diagnosis, to imaging, and to therapy in pulmonary vascular disease. Paul.
Thanks for this opportunity to talk about our work in signaling in pulmonary vascular disease. Pulmonary arterial hypertension, or PAH, as many of you have heard, is a unaddressed need in many ways due to the poor prognosis despite current therapies. It presents insidiously with shortness of breath and fatigue, but with an underlying progressive obliteration of the pulmonary circulation with this intermedial remodeling of the pulmonary vessels as shown here. And currently, all of our therapies are vasodilators targeting variously the endothelin pathway, the cyclic GMP nitric oxide pathway, and the prostacyclin pathway. But despite this era of modern treatment, our survival at 5 years remains just slightly better than 50%. And so, in order to gain insight into better strategies for modifying the disease, we've taken some clues from the genetics and the epidemiology of this disease. This schema shows that pulmonary hypertension can be driven by a whole host of systemic and cardiopulmonary conditions, but in fact, in the absence of many of these cardiovascular or cardiopulmonary conditions, idiopathic pulmonary arterial hypertension can be explained in a number of patients by heritable mutations, as many as 20% of these idiopathic pulmonary arterial hypertension patients. And we think that it's the identity of these mutations that presents an important clue into the etiology of this puzzling disease. And it turns out that over 2 decades of human genetics work has identified at least 8 or 9 different genetic lesions that can lead to this syndrome in the absence of other causative factors. And if we look at some of these lesions, they seem to preferentially affect one part of the bone morphogenetic protein TGF-beta signaling pathway, shown here, where TGF is known to traditionally use via its receptors and effectors induce myogenic and fibrogenic differentiation in a whole host of tissues. In contrast, BMPs are known for their roles in inducing osteogenic differentiation and having powerful effects on cell cycle control, particularly in inhibiting apoptosis. And you can see here that the canonical receptor, BMPR2, as well as its co-receptors, ALK1 and endoglin, its intracellular SMAD effectors, as well as the ligand itself, BMP9, all are associated with loss of function mutations in not only heritable pulmonary arterial hypertension, but a number of overlapping vascular syndromes, including hereditary hemorrhagic telangiectasia syndromes here. So we've since confirmed in every animal model that we've been able to get our hands on, whether they're genetic or toxin or hypoxia induced, that there is this remarkably conserved signature of imbalanced activin, TGF-beta, and BMP signaling, such that there seems to be a paucity of BMP signaling in the face of unopposed TGF or activin signaling. And this has also been observed every time there's been tissue to query this in lung tissues from every type of pulmonary arterial hypertension patients. So we tested whether or not this imbalance actually is a driving principle using pharmacologic approaches. And first of all, we've done something very simple, which is to administer supraphysiologic doses of BMP9 systemically to animals that have been actually 4 different models of pulmonary hypertension of either toxin-induced or even genetic models of pulmonary arterial hypertension. And we and our collaborators have found that this is actually quite a potent way to inhibit the pulmonary vascular remodeling and to improve the pulmonary hypertension and survival of these animals in a way that doesn't seem to be possible with traditional vasodilator therapies and can even reverse the existing remodeling and established disease in these models. And similarly, we've taken an approach of binding some of the unopposed TGF-beta ligands using a ligand trap TGF-BR2 expressed as a soluble Fc receptor, and shown that we can similarly improve the remodeling in pulmonary hypertension in these same animal models. And so this paradigm would seem to constitute one part of the pharmacologic epistasis. And to carry this further, some members of our team have recently identified in non-genetic forms of pulmonary arterial hypertension, in this case portal pulmonary hypertension, that there is an acquired deficiency of BMP9 expression in the circulation, which we suspected might be causative. And in fact, when we trap BMP9 ligands with the receptor trap, ALK1FC, its cognate ligand, we find that we can severely worsen the pulmonary hypertension and pulmonary vascular remodeling such that the mild remodeling that's seen normally with hypoxia is compounded severely when combined with this ligand trap with this severe intimal medial remodeling shown here. Okay, so we're currently exploring how these different pharmacologic strategies to rebalance signaling as a paradigm might be used in clinical settings. And we're also trying to devise more selective approaches to rebalancing the signaling in this pathway. Now, I've shown you a little bit about the genetic imbalances that can be associated with some cases of pulmonary arterial hypertension, but admittedly these are rare. So we wanted to understand some of the epidemiologic contributors, and when we look at some of these associated systemic diseases, it's clear in the case of HIV, scleroderma, or lupus that infectious or inflammatory drivers may contribute. And then in other conditions like congenital heart disease and portal pulmonary hypertension, two states known to be associated with high cardiac output and high flow states, that perhaps high shear stress might be a contributor. And in this case, we've tested this directly, experimentally, by inducing pathologic shear stress in cultured microvascular endothelial cells taken from unaffected individuals, as well as individuals with pulmonary arterial hypertension. And what we found is that unaffected microvascular endothelial cells will readily orient to this gradient within 48 to 72 hours, shown here, orienting along the axis of flow. But that, and this is a conspicuous and very consistent finding, that in the presence of group 1 PAH, these endothelial cells have a delayed capacity to orient to the direction of flow. It can be overcome with time, and eventually they will orient. But there are other defects that are obvious in these endothelial cells that look fairly innocent and normal at first. When we experimentally induce turbulent flow using bifurcations in this same flow system, we find that unaffected cells can survive turbulent flow without too many problems, but there is an increased propensity to loss of barrier function, to loss of cell-to-cell contact, and even apoptosis induced by turbulent flow, and we see this consistently in disease-derived cells. And this is true in the presence or absence of causative mutations. So when we've examined by RNA-seq the genes that are regulated by turbulent flow or high shear stress, we find that these genes are diametrically opposed to the genes that are regulated by BMP signaling. So we believe that these environmental challenges represent a stimulus that's very closely related mechanistically to the genetic forms of this disease. Now, I hope I've shown you that BMPs are important in pulmonary vascular disease in regulating the fate of vascular cells in vascular homeostasis and in endothelial cell fate. We've tried to extend this paradigm that pulmonary hypertension is a state of dysregulated angiogenesis as a potential way of having a non-invasive tool for detecting pulmonary vascular remodeling. So it's been known that VEGF is overexpressed and other angiogenic molecules are overexpressed in the lesions of pulmonary hypertension, in this case shown here in this plexiform or complex lesion that's obliterated in an arteriole taken from a patient with heritable pulmonary hypertension with a known BMPR2 mutation. And we've been able to extend this finding, showing that animals that are induced to develop pulmonary hypertension as a result of exposure to the VEGF inhibitor Sugen 5416 combined with hypoxia develop VEGF expressions shown here as fluorescence of the distal arterioles of the lung tissue that's absent in unaffected animals, except for the proximal central vessels. And so we've taken this concept and found that we can in fact use radio-labeled VEGF antibody, in this case 89 zirconium tagged to bevacizumab, which is a clinically approved VEGF neutralizing antibody, and find that we can detect angiogenic activity or expression of VEGF in the distal lung tissues shown here in the cross-section of this diseased animal, and in the peripheral lung fields here in the coronal projection, which is absent except for in the blood pool, the central vessels of our control animals. And so we're hoping that this might be a strategy for detecting early changes and possibly detecting interventions that might be disease modifying. And recently we've been awarded a grant from the Boston Biomedical Innovation Center to extend this concept into patients, a limited set of patients with pulmonary arterial hypertension. So to summarize, our lab is keenly interested in understanding further the mechanisms of this disease, and we are pursuing preclinical tolerability testing of some of these strategies for rebalancing signaling and eventually clinical validation. We hope that some of these strategies can be refined with more specific approaches to modifying signaling. And we're looking at the interaction of genomic and environmental factors in the hopes of identifying novel targets. And finally, in our work with cellular phenotypes and circulating biomarkers, as well as this new molecular imaging technique, we're hoping to identify disease at earlier stages where the interventions might be more successful. And if we're able to extend these to wider populations of patients who are at risk, we might hope to extend this paradigm and ultimately use tools like this to identify true disease-modifying therapies. Thank you.